Hello, everyone, and welcome to another episode of UNC's Therapy Thursday. My name is Evan Adler. I am a physical therapist here at UNC, and I am your host, curator, moderator, sometimes presenter of Therapy Thursday. It's brought to you by UNC Therapy Services and the Community Engagement Committee. This is our way of providing information back to you, the community, on some topics that we felt may be of great interest or have been requested of us to present. We do this on a monthly basis. If you have missed any of our talks from the past and want to find out about talks for the future, I ask you to go ahead and like and subscribe our YouTube channel. You can just search for UNC Therapy Thursday and our Facebook page for UNC Therapy Services, and you'll find out, find out about upcoming talks and events. So today we have another talk in the audiology realm. A couple weeks ago we had one from audiology on tinnitus, and today we're gonna turn it to more of a pediatric topic. So I'm going to go ahead and turn it over to Caitlin, who's going to give us a talk on early hearing loss and child outcomes. Caitlin, take it away.
Perfect. Thank you so much for hosting this, Evan, and for letting us be involved. Audiology kind of like really straddles the line between like a diagnostic profession and then a therapeutic profession. But here at UNC, audiology is part of our therapy services. And I will never miss an opportunity to tell people about hearing loss in kids and really recruiting people in the therapy services to be looking for what are the signs and symptoms of hearing loss, especially in kids who we know pass the newborn hearing screening. So I'm so grateful to be here. Kind of talking about early childhood hearing loss. My name is Caitlin Sapp. I'm a pediatric audiologist, first and foremost, a clinician, and I head up our pediatric audiology clinic here at UNC Chapel Hill Medical Center. I'm also a researcher under the UNC School of Medicine. I study child outcomes. I'm kind of part of a big longitudinal study that really spans several clinics going back for the last 10 to 15 years, examining child outcomes in kids with early identified hearing loss. So I'm going to might have a little more research than you're looking for, but that's kind of my bread and butter is what are the best tools available to us to say what's important, what works, how do we serve families of kids with hearing loss? A couple of financial disclosures. I'm a salaried employee at UNC Medical Center, and then I'm currently named on 2 NIH-supported subawards to UNC School of Medicine, one from Boys Town National Research Hospital and one from the University of Iowa. A couple of non-financial disclosures. I'm on the editorial board for AJA, and then I'm on the advisory committee for our Children's Cochlear Implant Center here at UNC. I also always list the caveat that I am an audiologist, so I work with families who choose listening and spoken language when their kids are identified with hearing loss. Not to say that I certainly don't see families who use sign language, but my in particular research and clinical specialty are in working with families who choose spoken language. I'll talk a little bit more about it kind of in a little while. Today, I'm going to cover a couple things. I'm going to talk about just like what are the prevalence and incidence of early hearing loss, especially if you're not an audiologist. I think it's easy to forget how common this is in infants and young children. I'll talk a little bit about why does early hearing loss matter, kind of what are some of the most important risk areas that we see in kids who are deaf and hard of hearing, and then identifying hearing loss outside of a newborn hearing screening. We all are really aware that the newborn hearing screening takes place. But if that doesn't pick kids up, what are the other common catchment points? And that's especially where I think colleagues in the therapeutic services could come kind of into play, helping us catch some of these kids who slip through our fingers. So I'm going to start with a really big picture. So every year in the United States, more than 3.7 million infants are born, and almost every one of them receives a newborn hearing screening. We screen infants for hearing loss for 2 main reasons. Because hearing loss is the most common condition that we regularly pick up at birth. We also screen because when we find hearing loss early, we can provide early access to intervention, and by extension, early access to language for these kids who are learning. So of those 3.7 million, this is 2018 data, about 40,000 of those babies don't pass that initial newborn hearing screening. And even looking at the 39 or 40,000, most of those kids we identify as having typical or normal hearing, leaving about 6,000 kids in the United States who are identified with hearing loss at birth after a failed newborn hearing screen. Of those 6,000, they're kind of split between kids with hearing loss just in 1 year, unilateral hearing loss, and then kids with bilateral hearing loss. Narrowing in even further, kind of thinking about the kids who are at the greatest risk, kids with hearing loss in both ears, those are spread between kids who are severe to profound, or what might really be thought of as traditionally deaf. But a much larger number of those kids with bilateral hearing loss are in the mild to severe hearing range. So they have aidable hearing. They may be a good candidate for things like hearing technology, using hearing aids. For children in the severe to profound range, sort of the path is pretty well defined. They will either move forward with a sign language like ASL, or they may use a cochlear implant. So there aren't kind of a lot of really, to facilitate language, we can't rely on good residual hearing, but a much bigger group have this residual hearing and may give really strong behavioral responses to sound. So it may not be clear to parents and families, caregivers, therapists, that the hearing loss is present, and they may miss time when they could access intervention. Infants with children with hearing loss really benefit from early identification because we can really use that information to turn back on their access to sound through intervention. So our national goals really drive us to screen for hearing loss no later than 1 month of age, refer for diagnostic testing and confirm hearing status by 3 months of age, and then hopefully enroll children in early intervention by 6 months of age. So kids with hearing loss all qualify for IDA Part C services. Hearing loss in infants is kind of considered an auto qualifier, and that's up through age 3. So even if kids are identified at a later age, 12 months, 18 months, 20 months, we're still making that referral for early intervention. Hearing loss, I think a lot of people are aware of in the context of older listeners, and here's kind of the World Health Organization definition, really looking at a person who is not able to hear as well as someone with normal hearing, really defining it by the thresholds. What is the level which we are seeing hearing loss? And kind of an old nomenclature really looked at degrees of hearing loss. So I have mild hearing loss, moderate to severe, profound. Hearing loss can occur in one ear or in both ears. The point being that it leads to difficulty in hearing conversational speech. Certainly there will be people with hearing loss who also can't hear environmental sounds, and that's important, but our main goal in looking for hearing loss in early ages is our kids having access to speech and language. I'm going to show a graph that sort of shows some of the most common things that are identified by newborn screening, either formal screening through the blood spot screen or picked up via visual sort of screening. Along the x-axis, you kind of see the different conditions, and then you're looking at the incidence per 10,000 cases. So for every 10,000 babies that are born, we kind of have things that people are pretty commonly concerned about. For example, Down syndrome, people kind of are aware that who might be at risk for that, and they're screening for that. Hearing loss really is almost twice as common as any other condition that we regularly screen for at birth, but we tend to have a lot lower awareness of it in our community and sort of the risk for it. Looking at prevalence of hearing loss, in about 1,000 infants, we will pick up maybe 1.7 of them. That's using 2019 CDC data. For every 1,000 infants born, we pick up between 1 and 2 of them who have detectable hearing loss at birth. Looking at North Carolina's birth numbers, that's about 250 babies who are born in our state every year with permanent hearing loss we identify at birth. When we look at babies born in the NICU, some state studies put it up to 10 times higher than the well baby population. So looking at higher risk infants who may also be in touch with things like PT, OT, maybe seeing speech for feeding therapy, their rate of hearing loss is going to be significantly higher. When we sort of put incidence aside and jump to prevalence, or how much hearing loss is present in the community at any given time, the prevalence of hearing loss jumps to 6 to 10 per thousand by the time kids are school age. So if you look at the population of school age children. So sort of where are those kids coming from? Is their hearing loss present at birth and being missed? Is hearing loss happening later? And how can we find out about those cases of hearing loss as early as possible? And I'm going to talk a little bit more about what we should be looking for kind of as a medical center team. Thinking kind of about hearing loss, make sure we're all on the same page with our ears. There's the part of your ear that you see in the mirror. And maybe some people think or never think about it. That's the part they see and think there must be sort of more than what I can see. Typically, sound will travel down the ear canal and hit the eardrum. The eardrum should move to send sound across 3 tiny bones, plink, 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 and deliver sound to your inner ear. It's a fluid-filled organ full of thousands of tiny hearing cells called the cochlea. They process that, really unique processing depending on what sound you hear, and they send that message up the nerve to your brain. Where your brain really is where hearing takes place. It's knowing there's a sound in your environment, and over time knowing what that sound means, learning those patterns. And hearing loss can happen at any sort of point in that system. So earwax can block the ear canal, creating kind of an obstructive hearing loss where overall things seem a lot softer. Hearing loss can happen in the middle ear if those bones are damaged, if fluid were to sit back there like in an ear infection. And then finally, the most important or permanent type of hearing loss is damage to those inner ear hearing cells or to the auditory nerve. And really, kids are at risk for hearing loss of every type. So there's no sort of part of the ear that we're looking at that we really don't need to keep a weather eye on kids in their development to make sure there's no educationally or developmentally significant hearing loss. For kids who pass the newborn hearing screening, ascertaining kind of when a hearing loss happened can be really complicated. So in the presence of, for example, at 2 days of age, you pass your newborn hearing screen. If we come on and find hearing loss later at age 1 or 2 or 3, figuring out exactly when that onset can be tricky. So there are cases of true late onset hearing loss where a child might be born with typical hearing or normal hearing and then have later onset. And there are some conditions that are really kind of associated with that you may see present in some of the patients you take care of. An example would be enlarged vestibular aqueduct or Pendred syndrome. There's acquired hearing loss, so sort of as the result of a condition that's acquired late onset after that newborn period. For example, aminoglycoside sensitivity. There are some kids who are genetically predisposed to sort of endure hearing loss if they're exposed to like gentamicin, for example, in the newborn nursery. And then finally, there are some cases of progressive hearing loss that stems from a congenital issue. For example, cytomegalovirus often results in hearing that is typical or normal right at birth. So those kids may pass the newborn hearing screen, but sort of experience rapidly progressive or deteriorative hearing loss and even the first few months of life. Looking just at hearing loss that's present in newborns that we pick up, the vast majority of hearing loss in infants is going to be genetic, even if this is a family that has no previous experience with hearing loss. Genetic causes are the most likely explanation for hearing loss, even in cases of no known risk. Of those genetic, the vast majority are non-syndromic, so hearing loss happening alone. No reason to look for hearing loss outside of the newborn hearing screening. And that leaves about 30% that are related to some other sort of induced cause. So prenatal or perinatal exposure, intrauterine infections, anoxia, sort of birth injury related hearing losses. And there are some cases of maternal diabetes that can be associated with hearing loss. Of acquired or late onset hearing loss, we talked about a couple of these, but moving forward, so CMV is a really common one when it's congenitally identified, EVA, some medications, meningitis, bacterial meningitis in the newborn remains a really big population of kids who develop hearing loss later. And so you may see if we're sharing patients with an inpatient that you may see an audiologist whose note sounds a little bit like they maybe are panicking, because when we find those cases, we know that we need to act really, really quickly since hearing loss is so common. And then head injuries, and then we may have talked about this a couple weeks ago with the Therapy Thursday talking about tinnitus. Noise exposure can cause hearing loss and tinnitus in children the same way. It's also always worth pointing out that our newborn hearing screenings are not perfect. We take a lot of pride in our newborn hearing screening programs, and nationwide, almost 99% of babies who are born receive a newborn hearing screening, but they are not without fault. Some cases of very, very mild hearing loss or especially strange configurations of hearing loss can be missed. A baby passes, but they did have hearing loss present. There are still infants who are missed. So for example, I staff in our NICU here at UNC, and there are some babies who are in the NICU for weeks and weeks and weeks, and we haven't screened their hearing yet. And then before we screen their hearing, they transfer to the floor. So at that point, they're outside kind of our typical processes for getting a newborn hearing screening. And we do still find cases where, it just wasn't on the discharging team's radar and a baby is missed. When we know about that, we bring kids in as soon as we can, but it's easier to just not miss them. And then there's something called auditory neuropathy, or hearing loss that comes from either the synapses or from the auditory nerve. I won't spend too much time on it, but it's kind of a special configuration where The hearing loss may be present at the level of the nerve, but if we're using a really peripheral hearing screening, we can see kids pass that newborn hearing screening and then later be identified with this neural family of hearing losses. Move on to part two. So why does early hearing loss matter? Now, if maybe I've convinced you, like it's very common, we need to be on the lookout all the time. What are really the risks that we're talking about? And what are the things we risk leaving on the table in terms of child development if we don't pick this up as sort of as soon as we can? Thinking about identifying hearing loss in children, I always urge when I teach audiology students this, or when I talk to speech and language students, hearing loss in an infant or a very young child looks really different than hearing loss in an adult. Hearing is so crucial for speech and language, and we'll look a little bit at that model, but an adult who has a lifetime of hearing experience, an auditory experience, really putting together the sounds of language and the sounds of your environment, they certainly will have adverse effects of hearing loss, but it's going to be a really different manifestation in terms of what risks are we most concerned about. Children are learning language for the first time. They're using their ears really functionally compared to an adult who may have experienced hearing loss deterioration. They may have made some accommodations and compensated for that hearing loss. A level of hearing loss that might be not noticeable to an adult, or they may have such slow onset that they don't feel it coming on until they really notice severe problems, might mean big developmental concerns for a child. So they're missing out on the auditory experience that sort of shapes language development, educational attainment. Again, with that, my big caveat that this is most sort of important for families who choose spoken language for their children. A visual language like ASL, as long as they have consistent visual access to it, results in that same exposure to spoken language. In infants and children, we really are looking for what is their access to language, knowing that language is so paramount to their educational, academic, and vocational success. And we'll look at a little bit of data about that. What we're most concerned about, will there be delayed or impaired speech and language development? Are they at risk for underachievement compared to their academic potential? And then what are potential social emotional problems of dealing, of having lack of confidence around their language, of struggling compared to their peers in a classroom? We struggle with hearing loss because it's often invisible. The same way that other protected disabilities, think about physical disabilities, or even if a person with low vision were to use glasses, those are really visible to communication partners. But because hearing loss can't be observed, we really may rely on alternative methods to pick it up and really looking for the signs and symptoms of hearing loss in a child compared to things like, for example, a physical disability where you may notice a difference in how you observe a child's gait over time. The signs of hearing loss might be more subtle, and it results on looking for behavior in space, which if you take care of a lot of kids, you might know sometimes kids seem like they're not paying attention and looking for those signs related. Could this be hearing loss, or is this a behavioral manifestation? We use this phrase all the time, and it's from the American Academy of Pediatrics. They teach in all of their educational materials, partnering with early hearing professionals. This is a developmental emergency. And it's printed kind of on all of their inventories about spoken language. And I would urge all of my colleagues, when you see sort of the signs of hearing loss, treat it like an emergency, knowing that hearing can often be kind of a gateway to other intervention that you might be doing. Perceptual impact of hearing loss for kids, thinking about reduced or inconsistent audibility of speech sounds. So if you're learning speech for the first time, you kind of think about most kids not using their first spoken word till around a year. You know, you really spend the first year of your life, although you're not producing any language, exposed to language. So overhearing, incidental learning. And issues with hearing can lead to language delays, poor vocabulary and reading, and then reading, understanding emotion. So the prosody or the suprasegmentals of speech. What is like when I'm reading between the lines with your voice, all of those skills that can be a little bit more subtle. And that will vary based on the level of hearing loss that we see. We also know that for any amount of hearing loss, this goes for children and adults, listening in background noise will be significantly more difficult than for their typical hearing peers, leading to inattention, what seem like inattention or behavioral problems in a classroom. And then we see something called listening fatigue, where the same amount of listening or engagement, if a child is using a significant portion of their cognitive resources just to hear what's happening, for example, in a classroom, there's going to be fewer cognitive resources, or you're more likely to deplete your cognitive resources just attending to a common task like listening in a classroom. this is sort of a graph from one of our papers. I'm a member of the Outcomes of Children with Hearing Loss study, as I mentioned, that's centered at UNC, University of Iowa, and Boys Town. And it's a longitudinal study that looks specifically at kids with mild to severe hearing loss. So maybe kids who accessed a newborn hearing screening, kind of a modern generation of kids who used maybe hearing technology, who are benefiting from early intervention through newborn hearing screening. And here we look at the plotted composite scores for children with typical hearing or normal hearing, and then kids who are hard of hearing. And you're looking at standard scores. This is kind of a composite language score among 2-year-olds, 3-year-olds, 4-year-olds, 5-year-olds, and 6-year-olds. The hashed region at every sort of age range shows the standard scores for this composite language score with a standard deviation of 15. So the one thing I will say is two kind of things pop out at me across this graph, and I'll point them out. So among normal hearing and hard of hearing listeners in the open circles, the hard of hearing group, the hard of hearing students have language that's significantly poorer than their typical hearing peers. And by 5 to 6 years of age, this magnitude in difference is nearly a standard deviation. If we look at the hashed region of typical developing scores on the normed sort of set of this data, though, it seems like kids with hearing loss are keeping up. So not all is lost. We are still seeing that kids with hearing loss are achieving what might be considered age-appropriate language scores in many cases. But compared to their kind of demographic matched normal hearing peers, they may not be unlocking their full potential, leading to the conclusion that children who are hard of hearing are at risk for language delays. And that may just be enhanced as age and time passes. Overall language outcomes comparing children who are hard of hearing versus children who are deaf is really important, knowing that children who are hard of hearing rely likely on amplified signal, but they still are using spoken language versus some kids who are kind of big D deaf or who are part of the deaf community may be more reliant on ASL. Looking at kids who use spoken language, kind of a few big takeaways from the literature on language outcomes. We see overall depressed language levels compared to their typically hearing peers. We see slower rates of language growth, and that seems especially true in kids who are not sort of full-time the most successful users of hearing devices. So we see slower rates of language growth in kids whose hearing aids or cochlear implants are poorly fit, kids who get them late, so who maybe spend more time without listening via that hearing technology, or kids who never receive devices. Syntax and morphology for spoken language users appears to be at special risk. So things like vocabulary maybe are more preserved than some of these fine structure syntax and morphology changes. And then many studies show deficits compared to typical hearing listeners, even in kids who have one normal hearing ear, so who listen with hearing loss in one ear alone. When we look at their educational outcomes, we kind of think about how exposure to sound really is the first step in the sequence of learning. So building on fundamental language skills is a big part of education. I know everyone kind of knows that adage that up through 4th grade, you're learning to read, and at 4th grade, it really flips and you start to use those reading skills in order to learn. I think that's the same thing with language. You're learning language for so much of your early childhood to then use that language to learn other important skills. And sort of thinking about how an educational and learning sequence happens first through exposure, but it's not enough to be exposed to that. You also need to have adequate perception and then experience with that novel stimuli. That leads to skill development and eventually the functional use of language, as I mentioned. Now, using that language to unlock other educational goals. And it can have cascading effects if that sequence is interrupted or depressed in any way. This is an older study that looked at vocational attainment and found significant impact of early hearing loss, even later with kids' ultimate educational attainment. Did they go to college? Were they less likely to go to graduate school? And then what their vocational ended up being. We know that increased audibility via hearing aids has the power to really moderate this risk. And I cited this Tomlin study here that said the ability of children to really access speech via their amplified signal, via their hearing aids, really makes an impact in what at least short-term educational lists are. So when I talk about audibility, that's really the whole point of what we perceive when we proceed with hearing aid fitting. If audibility is the potential, how much access does a child have to speech sounds, that can be determined by distance, by how poor their overall hearing is, and are they or are they not wearing hearing aids? And we sort of over in the audiology clinic are taking some sort of important steps to make sure that they're high quality hearing aid fittings Once we know about the hearing loss, we want that to result in early access to language through well-fit hearing aids. So for the last kind of part, I want to talk about what happens when we don't pick up kids at that newborn hearing screening. What are our other paths for identifying it? I think we've probably all maybe are convinced newborn hearing screening is effective and it picks up a lot of kids. But what we see is by the school age years, we have a lot more that we need to find, and we can't then go back and rely on that newborn hearing screening. This is another study that looked at timeliness of service delivery for children whose hearing loss was identified later. So this is a group who passed the newborn hearing screen, 57 kids, compared to kind of a matched group of kids who were identified with hearing loss from the newborn hearing screening. And it really looked at what the patterns were for how did we find them and what did we sort of narrow down in once we found them. So a review of their medical records really said that one big important group of kids we find later are kids who did not get a hearing screening. So these could be kids who are coming onto your caseload, things like were they foreign adoption? Were they like an out of hospital birth? So for example, kids who had a home birth or were born in maybe a delivery center that doesn't have newborn hearing screening. There are very few of those and they should be making recommendations, but the handoff can really be a time when babies can get lost. Some of the kids who were later identified, we were ended up being able to say, oh, you didn't pass the newborn hearing screening and you were lost to follow-up. So it wasn't maybe that you had true late onset hearing loss. It could have been that this was a hearing loss present at birth or a false pass on a screen, something about the child's hearing loss configuration. But they did find that about 40% were true postnatal onset. So things were associated with progressive hearing loss, things like that enlarged vestibular aqueduct or Pendred syndrome, and then some of the known acquired hearing loss. So the same things that we really consider our major risk was borne out in the literature that these are important referral reasons. If we sort of know that these are a special risk for late identified hearing loss, we want to make sure we're proactively following those families. And still sort of remained about a third that we couldn't really isolate. It might have been at birth, it might have been later, with the inability to really narrow it down. If you can't narrow down when the hearing loss happened, it's hard to know what was the length of time that children spent without quality access to spoken language. As audiologists, after the newborn hearing screening, we really rely on surveillance in the medical home and in the community to help us identify these cases of late onset or progressive hearing loss. Common catchment tools include referrals for, I see a little typo in my slides, that should say referrals for speech and language delay. I think if you're a pediatrician or if you work closely with pediatricians, you see that that's a common referral reason for including a hearing test. If you're a speech language pathologist, you may notice, oh, I've checked, yes, all the kids who I'm doing evaluations with, have we rechecked their hearing since the newborn hearing screening? There are some states in which Medicaid really requires a repeat hearing test before they will move forward with speech language services, with compensating those services. And that's probably the most common reason clinically we identify some of these known cases, things like CCMV or enlarged vestibular aqueduct. You know, the original referral came in based on a speech and language delay, and only once we knew about the hearing loss and really launched this kind of investigation, the Sherlock Holmes of hearing loss, were we able to identify that was likely one of the causes. In the pediatric medical home, relying on developmental skills inventories, things like the MCHAT, are there especially marked concerns for responsiveness to sound, to environmental sound, to their name? Are they displaying age-appropriate auditory skills? Some parents also bring true hearing concerns. It might be based on an overall feeling compared to other kids I see who are maybe 3 or 4. My own child doesn't seem like he is as responsive. I have a harder time getting his attention. I can't call him from down the hall. Or it can be a specific instance. So, you know, he was standing by me in the kitchen looking away and I dropped a pot of soup. Loud clanging sound, no awareness at all. So sometimes it can be as easy as that one instance really got a parent's really concern bells ringing. That's really reason enough for us to repeat the hearing test. And then there are some cases of known risk factors for late onset hearing loss that might be identified either at hospital discharge after birth, and those we try and record at the same time with the newborn hearing screening. So, yep, today is a pass, but we want to see you back in audiology for one of these specific reasons. We follow children with concern for hearing loss closely, given the serious risks and consequences of delayed diagnosis. Once the hearing loss is present, Every day spent without intervention is really a day spent with restricted access to amplified sound. Especially in cases of mild to moderately severe hearing loss, hearing aids are going to do a really, really good job at restoring auditory access and facilitating auditory experience. With sort of special concern for some of these same skills that I've talked about, and this is kind of from the effects of hearing loss as a developmental consideration. Among my team and among every pediatric audiologist I know, we can never say it too many times, parent concern remains our number one risk factor. This is kind of the last of these, I think, research studies I'm going to show you guys, but it's from a paper that looked at this later group of hearing loss that I mentioned before. So thinking about kids who were identified later in the darker bars versus the group who was identified after newborn hearing screening. Looking at their age when we first identified their hearing loss, so you can see that compared to the newborn hearing screening group here on the left, the group who was identified with hearing loss later was identified significantly later. What was interesting, though, when you look at the pattern of service that the child was receiving before their diagnosis, on average, children with late identified hearing loss were receiving early intervention for over a year before they had their hearing tested. So up to 14 months of speech and language services, maybe treatment with an OT, maybe seeing a general early interventionist. All of that year or 14 months this child was receiving services, they didn't have the auditory access that they needed to make progress. So no matter how often you see a speech pathologist, probably if you can't hear the majority of those auditory cues, it's going to be really, really difficult to make progress on the skills that your family are reporting concerns about. As a speech language pathologist, I think that would be hard to swallow, knowing, oh, just spent a year with really intense services for this family, knowing now, oh, he or she likely couldn't hear many of the skills I was working on. That's time kind of you can't get back in terms of preparing for kindergarten readiness. I lied looking at one more study. This is sort of thinking, one thing I will say is many pediatricians push back, and the idea is, oh, I send so many kids for a hearing test related to speech and language delay. Is this overkill? Do we really need to test every child's hearing who has speech and language delay? And this is sort of a paper that looked at that question. Retrospective review of 654 children who got a hearing test related to speech and language delay. These were phenotypically healthy children, no additional developmental concerns, no other risk factors for hearing loss, aside from the fact that they had an observable delay in their spoken language. The results showed that more than 10% of them were identified with some degree of auditory disorder. Some of this was conductive hearing loss, the CHL group, about 5%, meaning that the child maybe had ongoing middle ear dysfunction, maybe ongoing fluid, an undermanaged health issue with their ear that might respond to medical management, but not if we don't know about it. But still more than 8% in this study came back with some degree of sensory neural hearing loss or a permanent type of hearing loss, showing that speech and language delay is still an important identification tool. It's an important catchment point once we're past the newborn hearing screening. Some other risk factors that we look for, this is the Joint Committee on Infant Hearing, is kind of our clinical practice guidelines related to early hearing loss. And this is a few of the risk factors you might see in some of the kids you take care of, and it might be worth sorting epic, maybe, has this child had a repeat hearing test? So babies who spend more than 5 days in the NICU, we want to see them back for a follow-up hearing test. These all sort of are indicated for a follow-up hearing test at 9 months of age. Exposure to aminoglycosides, gentamicin is the most common that we see in the newborn population. Known infections like CCC-A, children who received ECMO during their newborn sort of period. And then in the most recent update, we've added things like Zika. So Zika, the same way CCC-A, cytomegalovirus, carries risk for hearing loss, Zika is kind of the same way. We also found some updates related to how often we should follow for kids with CCC-A, and then providing some guidance related to how audiologists should be involved in newborn hearing screening programs. And then that major hearing loss risk factor that I kind of talked about, really taking parent and caregiver concerns seriously. I don't need to tell this audience, parents are experts in their kids. They see responsiveness in a natural context. So if they're coming to me and saying, yeah, I'm not sure he can always hear me, they're saying that with the experience of seeing their kiddo at home, with their favorite people, with their favorite toys, really motivating factors that I might not see the first time I see them here in a clinic. But if families are reporting specific concerns, I kind of stop everything and really take that seriously. They're aware of multifactorial considerations. So is there another family member, for instance, who has early childhood hearing loss? That might make me take their parent concern. They may be developing that concern with the knowledge of already having witnessed another child with early hearing loss. And then a parent can speak to changes over time. Maybe this is a new onset. It's something that they've only seen in the last 4 weeks or 10 weeks compared to earlier times where they can specifically point backward and say, yeah, they were very responsive to this and this and this in the past, and I don't see those same responses anymore. I would also urge us to consider concerns in a child's broader community. So we know that kids don't experience sort of one environment alone. So thinking about concern that are voiced by things like the classroom teacher, if they're in a preschool, if a child is already receiving speech therapy, even if they've maybe passed another hearing screening or if no screening took place, oftentimes speech therapists will escalate that to us and say, I think you should have a repeat hearing test. So urging families to take those referrals seriously. And then friends and family who may have a different background of experience working with kids who are deaf and hard of hearing, and are voicing that to parents to then share with their medical team. We would invite the referrals for anything, any sort of one of those individual risk factors for a true diagnostic evaluation by a pediatric audiologist. And this kind of just lays out a few of the tools we'll use. There's really no age range where we can't evaluate a child. So even if they passed the newborn hearing screening less than 6 or 10 months ago, we can evaluate that child's hearing, starting with sort of our least intense intervention options and then sort of escalating how much information do we need, including things like a sedated hearing test in instances of true parent hearing concern, and if a child who is not old enough to do behavioral audiometry or a behavioral hearing test. I always also want to share with my colleagues that if you have a patient who is new to you, for example, maybe a child who's been in foster care or who's wondering about the newborn hearing screening results, if there are patients who you wonder, did they pass the newborn hearing screening results? One of your audiology colleagues can really help you find that information to answer those questions, to kind of tick that box. Only by working as a team are we going to find kids who were lost to follow-up after the newborn screen. Here in North Carolina and every state in the United States, we track newborn hearing screening results using a public health secure database. Knowing that a well-developed state-level tracking database is the single best tool to help us eliminate and close the gap in loss to follow-up. So if you can't locate the status of a child's newborn hearing screening, any North Carolina audiologist should be able to help you track down this information. I get emails all over from people who are just trying to hunt down that information. I'm a pediatrician. I got a kid transfer in maybe from Charlotte or from out by the coast living with foster family now. We can help find that information using kind of the secure data portal with a little bit of information about that child to help us narrow down and eliminate their PHI being sort of shared broadly. So I've covered a couple different things today. I hope you learned a little bit more about the patterns of early hearing loss, including both congenital hearing loss and then later identified or later onset hearing loss, why hearing loss matters, how important hearing is for speech and language development especially, and then thinking about what are all of our roles in identifying hearing loss outside of that newborn hearing screening. Once we've sort of missed a child at the level of the newborn hearing screening, when's the next time we're going to get a bite at that apple? Knowing that timing matters for kids with hearing loss. The earlier kids access hearing technology who need it, sort of the less impact we see on their long-term language and educational impacts. I would like to say thank you to Evan for hosting me today, letting me come talk about what is obviously like my very, very favorite topic. And I don't think we have any questions. I don't see anything posted here. So I might hand it back to him.
Caitlin, thank you so much. No, we didn't have any questions today. However, I thank you so much for this talk. It was super, super interesting. As a parent of two small children, I always kind of wonder what to look for, and if there are some of these signs present. So this was very helpful. So what we'll be doing is today's was recorded, and this will be up on our YouTube site, where if you're watching this right now, you know that because that's how you're watching it. But I do encourage you to go and take a look at our other programs on Therapy Thursday. We have our YouTube site. Just search for UNC Therapy Thursday, and then you can visit our Facebook page. for UNC Therapy Services to find out about more upcoming Therapy Thursdays and in-person events that we will be doing as well. Let's see, today is October 27th, 2022, and our next Therapy Thursday is going to be in November, I believe 17th. And the topic then is going to be from our pelvic health group about constipation and pain. So a slightly embarrassing topic to maybe talk about, but one all the same important and interesting and felt by many. So, Caitlin, thank you again for your talk today. I really appreciate you coming out, and we hope to see you all soon. Thank you.